Good evening, guys. As I promised that I will be coming back this evening sometime with a lecture on the bilateral free end saddle or Kennedy class 1 cast partial dentures. So here is the small lecture on that. Bilateral free end lower denture. Actually, the upper denture is not a problem because it is having a lot of surface area to cover, and it does not provide us any problem in terms of retention and stability. Problem is with the lower free end saddle or class 1 Kennedy RPD. So this is the situation when we take the impression and when we pour the master cast. This is also known as Kennedy class 1 or bilateral free end saddle or bilateral distal extension denture. Distal extension. This is a tooth-borne as well as a tissue-borne RPD. The problems with these distal extension RPDs. In a distal extension partial denture bases always contribute to the support of the denture. This support is critical to the goal of minimizing functional movement and improving stability of the prosthesis. Though the abutment teeth, they provide some support, but as the distance from the abutment it increases, the support from the underlying rich tissues, it becomes increasingly important. Maximum support from the residual ridge is obtained by using a broad, accurate denture base, which contribute the occlusal load equitably over the entire area available for such support. How to counteract this problem? We should be having adequate knowledge of the anatomical structures, and we take the accurate impression of that area. Distal extension RPDs. The snowshoe principle, that is the broad coverage, it provides the best support and there is least load per unit area. The support should be the primary consideration in selecting, designing, and fabricating a distal extension partial denture base. Well, another thing is we go for the altered cast impression technique. And what is that? Let's see why we do that. Free end saddles are prone to displacement under the occlusal pressure due to the displaceability of the mucosa. To mitigate this, the altered cast technique is employed involving an impression of the mucosa under controlled pressure. Initially, a metal framework is constructed on a cast made from the mucostatic impression material, which I have shown you earlier. Base plates made from self-cured acrylics are then constructed on the framework. These are the in which the impression is taken. So base plates made from the self-cured acrylics are then constructed on the framework in the saddle area, ensuring a close fit. Border molding is performed and then another impression is taken like this. In the laboratory, the free end saddle areas on the master cast are sectioned off like this. They are sectioned off. And the denture is positioned on the model and the new saddle areas are poured. This process creates a model that represents the free end saddle areas under functional load conditions. Subsequent denture construction proceeds as usual. This technique improves the distribution of loading on the free end saddles, resulting in a more stable denture. Like this. Here we can see the color difference between the two model materials. This is the new model in the altered cast impression. What is this altered cast distal extension? A favorably extended base will provide stimulation to the underlying bone and distribute forces uniformly. The altered cast technique allows the ridge recorded in functional form to be related to the teeth so that when the prosthesis is seated, It derives support simultaneously from the teeth and the denture base. Why we take this all the trouble? Why all this laborious work? Metal frameworks made from the master casts, they must be adjusted to fit intraorally, and that may change the relationship of the teeth and denture base on the master cast. In tooth-borne partial dentures, which are Kennedy class 3 or small span class 4, this small change is negligible since the teeth they provide almost the entire support for the denture. Well, in the distal extension cases like Kennedy class 1 and class 2, the change can produce deleterious effects on the supporting residual ridge and or teeth since the load must be distributed between the two tissues. That is why a new impression, which is altered cast impression, is made with the partial denture framework over the intraoral adjustment to capture an accurate relation between the teeth, framework, and the residual ridge. Well, once the denture is done, it is placed in patient's mouth, we have to recall the patient again and again for the maintenance purpose. And relining of the bilateral free end saddles could be done if it is required. So distal extension RPDs, they require correction by relining or rebasing much more often than the tooth supported RPDs because most of the support is from the underlying soft tissues and residual ridges, and more occlusal loads are directed to the residual ridges through the prosthesis. The patient should be informed that a distal extension RPD requires periodic examination and relining due to maintaining the health of the abutment teeth and the residual ridges before the treatment. So this information has an important role in defending the rights of the clinician to charge the patient in periodic visits. Now, the question which was being asked, how to minimize the loading of the saddle area in this bilateral or unilateral distal extension RPD. Three important methods. Number one, which we have already discussed, snowshoe principle, which will provide broad coverage, best support, and least load per unit area. The second thing is take the second impression after your chrome cobalt metal framework is ready. That is altered cast impression for impression of the saddle area for close fitting. And third thing is regularly recall the patient every 6 months for the maintenance and check if relining is required. I can make another lecture for you guys if you want, how we check the need for relining in the distal extension denture and what are the methods for that and how we do the relining. If you need, if there was any question on that, you can always let me know. So relining, if it is required, is done. Well, how we design the direct retainers in this situation, which is Kennedy class 1. Tooth and tissue bone situations require special attention in direct retainer selection due to stresses created by rotational movements of the prosthesis. Under the occlusal stresses, rotation occurs about the rest seats of the most posterior abutments. Excessive occlusal forces on the distal extension portion of the denture could cause a torquing action on the abutment teeth unless direct retainers are designed with the stress breaking capabilities. And these stress releasing clasp assemblies, they include the bar clasp with the mesial rest, which we call the RPIs, rest, proximal plate, and the I bar clasp, or the RPA clasp, and combination clasp. This combination clasp is not very commonly used because in that the rest is on the disto-occlusal area. We want mesio-occlusal area. That is why we go for these two options. And why we don't want the disto-occlusal surface, I will explain that to you in a bit. This is the RPI clasp. R is for rest, always mesial. We can see it from the lingual side, we can see it from the occlusal side, and from the buccal side. Then the proximal plate, proximal plate, proximal plate, and the eye bar. Well, this clasp assembly is similar to the RPI design, which we call RPA clasp, except a wrought wire circumferential clasp, which is known as Akers, is used instead of the eye bar. This clasp arises from the proximal plate and terminates in the mesiobuccal undercut like this. Mesiobuccal undercut. It is used when there is insufficient vestibule depth or when a severe tissue undercut exists, which does not let you use the eye bar. So this is RPA clasp. A is for Akers. Why we do not want the distal rest? The use of the clasp assembly with a disto-occlusal rest in a distal extension case could lead to distal tilting and possible loss of the abutment tooth. We can see it over here. Under the occlusal rest, it will be fulcrum, which will cause some leverage on the tooth, and maybe in the long term, the tooth is going to be lost. Indirect retainers and the fulcrum line. Movement of a distal extension base away from the ridge tissue or the tissue away movement, it occurs via either displacement of the entire denture, which is resisted by the direct retainers, or it is a rotational movement about an axis. This axis passes through rests of the most posterior abutment teeth, and we call it fulcrum line. So over here, you can see one situation for the bilateral distal extension, or another situation for the bilateral distal extension where premolars are missing on one side, but on the other side, premolars are present. So rotation of the partial denture about the fulcrum line is prevented by placing the indirect retainers at the right angle to the fulcrum line. But in this situation, the right angle is going between the two central incisors. Hence, we are going to use both the canines for that purpose. Indirect retainers should be placed as far as possible from the distal extension to gain the best possible leverage advantage against lifting of the distal extension base. So over here, we can see the design of the Kennedy class 1 bilateral in the mandibular arch. This is the distal extension. Then we have the direct retainer with the mesial rest on it, and then the indirect retainers. These are the direct retainers, and these are the indirect retainers. Home care of the RPDs. Removable partial dentures, they require different hygiene care from the natural dentition, and association of brushing and chemical cleansing is the most recommended to control the biofilm formation. According to these studies, mouth rinses containing cetylpyridinium chloride or chlorhexidine and solutions with acetic and peracetic acid, they could be safely used to chemically sanitize the chrome cobalt prosthesis. Alkaline peroxides should be used with caution, and alkaline hypochlorite solutions should be avoided, means sodium hypochlorite. Guide the patients that dentures must be cleaned extraorally to ensure effective cleaning occurs and to reduce the risks of issues from denture cleansing that may have adverse effects on the oral mucosa. This is the denture cleansing brush. I have used these references to make this presentation for you. So just for the authenticity, I have included these references over here. Thank you very much. Hopefully you have liked it, and any other further help you guys need, let me know, and I will be there to help you out. Thank you very much.